Yes, now.
Great, welcome, and thank you for joining us today for the first meeting of the New York City Health and Hospitals Finance Committee in 2022. Today's meeting is officially called to order. First, I would like to propose a motion to adopt the minutes of the Finance Committee meeting held on December 7th, 2021. I will poll each member for their vote. Jose Pagan,
Yes.
Sally Hernandez Pinheiro,
Yes, Teresa.
great. Fenioski Peñamora. Benny?
Yes, Hernandez.
Yes. And Barbara Lowe.
Yes.
Great. So the minutes are adopted. So I'm pleased today to announce we have no action items. So not that that's a good or bad thing, but that we actually have time to have a fulsome financial update from John Alberg, our Chief Financial Officer, and the whole financial team. So we frequently had to abbreviate that update. So hopefully we'll have time to get through some very good information. I know we also have some late breaking updates that are good news for us. So I'll ask that members hold their questions to the end, and I'll poll each member for their comments and questions after the presentation. So I'll turn it over to you, John.
Good morning and Happy New Year to everyone. It's great seeing you and having some time to go through the first quarter results. And I think this is primarily just a continuation of the discussion that we're going to have last month, other than the fact that we're in the midst of the fourth wave of the pandemic, the Omicron phase we call it. And we'll touch on that. I think people have done an excellent job responding to it. It's put stress on the system for sure. But I think we've done a lot of pre-planning, and I think putting ourselves into a position to respond. We knew it was a little tough weekend for our nurses and doctors, but we have plenty of reinforcements coming, and we'll go through from a numbers perspective how we've responded. I think in general, and Micheline will go through this, I think roughly 111 million is our estimate of how much we're going to spend in addition to the previous FEMA related costs. That's a 6 to 8 week estimate, and I think on the T2 side, Sarah will go through those numbers, but they're again pretty large numbers been added to the T2 budget, I think somewhere in the neighborhood of 160 million a month. So, and those numbers will all fluctuate, and Sarah's kicking me under the table now because I'm sure they've changed since we've put these on the slide. But again, I'll quickly go through the first couple of slides here. We missed the budget really for the first time in the first quarter by $152 million, but that is all really attributed to the fact that we did not receive the FEMA relief that we were planning on. And I will say we're very much indebted to the mayor and Senator Schumer and Congressman Torres. They are been strong advocates on the behalf of health and hospitals, and as recently as yesterday they had a press event, and we very much appreciate their advocacy. I mean, we know that we all run on about 22 days of cash, which is maybe I think the rest of the industries might be 10 times that high. So cash is very important to us, and we've done, I think, an excellent job to make sure that we always have enough money in the bank. But their advocacy is very important, and we hope as early as the end of this month that we will get another installment of payment from FEMA, and we'll talk about that. I think what's really on the bright side of things is that the revenue cycle continues to perform. We're $117 million higher than the same period last year. And then you remember we performed last year, we had a year-end target over the prior year of $468 million. So the trend line keeps moving up according to the plan, and Margie will go through some of those results and some of the things in particular that we're targeting. Prior to this last wave, we were seeing our volumes all return, but still slightly below what we were pre-COVID, 4% below on the inpatient side, 6%, but everything's still all coming back and looking pretty good. And then our strategic financial initiatives, we have a line of sight of 606 million, and we've achieved about 160 million of that. The 606 could come down. That's a number that we always keep an eye on, but nonetheless, we think we're doing an excellent job on the overall plan, and we'll talk about that here too, what's in the plan. But we list out, the areas where we see exceptional performance down below. That's the first one. James, do you want to do the second? Yeah, sure.
So just to give a brief update on our cash projections. So we ended November with about $450 million cash on hand, or about 20 days, right near the average, as John noted, of about 22 days in a given month. Our December number we expect to be a little bit lower. We're still closing the book, but it looks to be around $300 million, or about 14 days. December has historically been our low point, and in part with some payments to vendors who sometimes have a calendar year end number that they're trying to hit. Our cash can drop a bit, but the $300 million, we still feel stable about it. As John noted, over the next few weeks, we hope to get another installment from FEMA, as well as we're hearing good progress on our DISH payment, and we appreciate the state's effort there. We often do get a $530 million payment of DISH in January, and that seems to be on schedule, which will help us greatly. In addition, and throughout all of this, we are working with the city on any of our liabilities, and that sort of has remained the same as previous months. So we're feeling good about cash, but obviously continuing to monitor closely as we have, all the spending related to Omicron and T2 that we'll get into.
So as we said, through October, our total spending on the COVID response was $2.5 billion. At that point, we had commitments of $3 billion, and we continue to track where that stands with the spending catches up to the total contract commitments that we've made. We have, as has been noted, received $266 million from FEMA, and we're very happy, as everyone has said, to have the full approval of our request from FEMA for over $1 billion. That will enable us to receive this next payment of $354 million, which we anticipate getting but by the end of this month. We also have subsequent packages to present to FEMA, both to draw down the balance of the $1 billion that was already approved, and some additional requests for funding that wasn't included in that package, including for PPE in particular. We have, a separate from FEMA, received $1.2 billion from the Provider Relief Fund. That came in several ways, including most significantly funds for high impact areas, where we received $754 million. Funds specifically for safety net hospitals, where we received $359 million, and $69 million from a general allocation through the first 3 phases of the Provider Relief Fund distributions. We have submitted all required reporting related to the first tranche of that money. We have another report coming up due at the end of March, and we're on track to complete that timely. And lastly, there's a final, but another wave of provider relief funds that were recently released in December, and we received $15 million from that tranche.
Yeah, on the external risks, you know very well that we follow these risks. These are the risks that are primarily outside of our control, and those are the ones that concern us the most. And I think if we take a look back over last year when we were sitting here, the list was much longer, and I think had much greater concern about the list. But I would say for the most part, we've checked off most of these, if not all of them. The state and city Medicaid initiatives, the UPL conversion, we talked a lot about that last year. We secured those funds for the most part. We still have a couple of plans that we're working with, but feel very comfortable with that. And I will say that I think the plans have done, an excellent job working with us. These are unusual transactions, and I think the partnership that we've had with the plans were very healthy, and we certainly appreciate that. The state city budget risks, we feel very comfortable there too. The mid-year update from the state release of their financial plan indicated there's $4 billion in additional revenue beyond what they had in their plan. So that is, certainly provides a lot of, takes a lot of pressure off the budget. And, the governor's budget, I think by all accounts was a very healthy one, and targeted at health equity and the workforce. and even expanding insurance. We look forward to getting into the details of that within the next, couple of weeks. But from our early indication, it seems like there's a lot of very positive things for health and hospitals and other, safety nets. FEMA reimbursement, as I had mentioned, we're working with our partners at FEMA as well as with the state agencies referred to as dishes, right? They have a role. We're working very closely with them. And it is our hope that, as I indicated, within the next couple of weeks, we'll get the second tranche of funds, I think somewhere in the neighborhood of $350 million. So we feel pretty optimistic there, but we certainly have much more work to do with FEMA, maybe perhaps measured in years, but nonetheless, we think we have a good, relationship with them. And as I had indicated, we appreciate the advocacy. The vaccine mandate, right? We went through that. We hired additional, resources in preparation for that. And then as well as with the phase 4 Omicron response. That remains, I think, a concern, but nonetheless, we're spending the money when we think we have to, and we believe they're smart investments to help the city, respond to COVID, and it will pay dividends in return. We just have to, keep our eye on all that cash and then hopefully the payments that we receive back from FEMA and reimbursement from insurers. The next, you want to do this one?
So we've been regularly meeting to track how our volume has been unfolding. So to accommodate for that across the system, we have basically are investing an initial $111 million that John mentioned before to prepare the system from particularly a staffing perspective. So to do that, we activated or lined up a larger number of temp staffing than we would normally, and that is mainly to support our ICUs, our med-surg, our emergency rooms, and also COVID behavioral health units that are opening, as well as our nursing homes. So thus far, we've basically put in preliminary requests of about 800 FTEs across those areas across the system. We also added other vendors who would allow us to secure out-of-state resources to fill any specialized or critical nursing needs that we're not able to ramp up fast enough locally. We have also activated credential provider requests for staff. Agency staffing of about 287, close to 290 across the hospitals, as well as other non-clinical staff across the system, for example, EVS and other support titles. The other mechanism that we also looked at and would like to prioritize is basically our own RN overtime, and as well as RN and provider, both overtime and shifts, where we can ramp that up in a safe way. We would also activate that definitely as a first line in parallel to securing our agency temps. So those are the areas basically that are focused on right now with our staffing. Okay. So
I
this
wanted to
next
go back and make one comment before we do the new budget, just because I know that the board has heard for quite a while about the upper payment limit, and I was afraid to say it until it all started coming in so well, that when John first raised the idea of the upper payment limit, I heard a variety of voices, very knowledgeable, that it would never happen. That it would never, the feds would never agree, the states would never agree, the managed care plans would never agree, and it was very hard. I mean, it took a long time, it took a lot of negotiation, but now for the first time, I can say it really did happen. It really did happen despite all of the people who said it would never happen. And John, throughout the time, always said, there's no reason this can't happen. There's no reason this can happen. This is consistent with the rules. We can make this happen. We just have to keep working. And I really admire both, the idea that he had and the way that he was able to persist in the face of a lot of people saying it would not happen. And it's not only a source of dollars, but it makes our money come in a more regular way. And so we'll prevent some of the sort of crazy, jumps and dips in our cash flow. So John, you get I know a lot of people helped you, but again, you were the one who overall said this should be possible, we should be able to do it, and you made it happen.
Yay.
Well, I appreciate that, Dr. Kiss, but I certainly, there's a lot of people that helped out here.
I know.
A lot of people, and the idea was the easy part. So I appreciate the thought. But I do want to say there's a tremendous effort on all of our parts. Linda in particular, who helped us get there. So thank you.
Agreed. It took rewards to Linda, and I'm not, again, everybody worked very hard. I think what I think is worth as a lesson for all of us is that sometimes you have an idea and people say, no, it can't happen. And that doesn't mean you should always drop the idea. If you know that it's possible, then you keep at it and you keep at it. And that's what your staff did. And in the end, it worked. And that's what I think is the special lesson of the upper payment limit.
Well, thank you.
Thank you, Mitch. John, you want to keep going?
Yeah.
Yes.
So this one is a very high level slide that we have actually seen before, more in the form of a table. Just a high level summary shows the components, big picture of what we focus on with the fiscal 22 budget. So the first piece of it is building on all the initiatives and growth plans and successes that had initiated or had started in fiscal 21 with basically incremental progress with additional dollars for fiscal 22. The second piece of it is supporting citywide COVID recovery initiatives and other initiatives that are basically in alignment with our vision. Some of these you've heard about before, and we will speak about more later as well, like T2, NYC Care, Public Health Corp, Healing NYC. And then the third largest piece also of this budget was right-sizing our staffing models, including nursing and EVS. And we're looking at that right now, or reaping the benefit of that now as we plan for Omicron, as having a baseline that we can basically use to predict based on as we project our census numbers.
Sure, and just a reminder of sort of our most recent financial plan, which was from the executive budget last year. This is just a very high level, showing our total revenues and expenses year over year. The total revenues in FY21 and FY22, you'll see, are much higher than the later years. That is the impact on the inclusion of our COVID and T2 spending that was estimated at the time. I think what we really wanted to just point out here was that we were showing positive income year end in FY21 and 22, a small negative in FY23, and then larger negatives in the later out years as the dish cuts return, which we've talked about many times. Those dish cuts have been delayed several times now, and we are hopeful that they will continue to be delayed. And in that instance, our net margin would remain approximately break even in all of the 5 years of the plan, given some of the offsets of things we have. The other big thing to point out is that through FY23, we do maintain strong cash balances throughout on the projected basis. And so, it really just gives a sense of how we're looking over the next couple of years, just to remind you, in relation with the budget.
Okay, so the next section, we'll look quickly at the financial performance, which John summarized in the beginning. But these are basically the graphs that show us where we ended quarter one Again, variance of the negative 151 million in anticipation again of the FEMA funding, with about 283 million on the disbursement side associated with COVID that haven't been offset as of Q1 with federal funding. So that's really one of the larger stories here. Also, another one on the disbursement side is that we've moved some of our larger vendors to electronic fund transfer. So from a cash perspective, we're catching up with some prior year payments there for some level of our OTPS spend. On the receipts side, real quick, again, exceeding budget here by about 192 million. 162 of that is in the patient care, inpatient and outpatient. We have our volume going back up, as John mentioned, close to our pre-COVID levels on both inpatient and outpatient. And also our rates, we're seeing on average some higher rates, and our risk also is coming in higher to some of the MetroPlus payments that were received this fiscal year on behalf of work from prior year. The next one, just a deeper look on the revenue side, 117 million when we look at this year compared to last fiscal year is what we're doing better by, and just something to remember here when we are looking at Q1 of FY22 versus 21, that in 21 we started seeing some of the dollars associated with our COVID patients hitting from a cash perspective as well. So that is also some of the offset that we see here for the variance versus when we look at it against budget. For patient revenue improvements, again, year to year, it's a combination of our higher volume, the solid performance on the revenue cycle and other initiatives that John mentioned at the start, and we continue to see these improvements unfold as we go throughout the fiscal year. Just a quick note, basically, that impacts the year to year is just there's an extra week. Just summarizing, that's 14 payments versus 13. That's worth about 23 million. I know that came up as a question before, so just to clarify what that is, it's a timing that adjusts itself as the year goes on. So just to be transparent with that. Same time last year, our discharges are up 16% and visits up 10%. So even though we're not up to the pre-COVID levels yet, but they are up definitely significantly enough to mention here, and our case mix index is also higher by 0.5%. Okay, so here we start just taking a quick look and just a deeper dive of an update on the strategic initiatives. So basically, at the start, we had mentioned that our Q1 fiscal 22 performance, it's at 160 million, and this gives us about 606 or so million for line of sight at the annual value for the end of the fiscal year. So this shows some of the components that feeds into these efforts. We still have the 340B contract pharmacy staying strong, that performance there. Our medical necessity denials reduction under also some of the revenue cycle efforts there. We have the service line improvements with our PACS and Gotham. And a good chunk of those improvements also relate to their focus on revenue cycle and other pieces that they're implementing. The revenue cycle initiatives is next at 313 million, and Margie will go through that in good detail later on. System-wide efficiencies, we're converting some or reducing use of some of our consultants across the system, particularly the use under EITS and Epic. And we have other initiatives there under that with labs and supply chain. And then lastly, another important piece is the value-based initiatives and some of our managed care initiatives there, where we are basically on track to meet and exceed our target for the year. And this is where you see our HARP SNP conversions our AmCare initiatives focusing on primary care, our primary care models and telehealth models and panel size alignment there. You also have the managed care high cost outliers in that bucket as well as our contract negotiations and settlements feeding into a good chunk of that, which is 93 million out of that 128. Just a quick note on the orange versus green. The reason this is orange is that there is more to come on our Q1 performance. It's a matter of timing and just the lag of incorporating those as the dollars come in from a cash perspective. So we should see more of that in the Q2 update. So it's not so much of a concern, it's more of a timing, and we will be presenting more on that when we meet next time.
Okay, so we wanted to walk quickly through the fiscal 22 revenue cycle targets. Through the first quarter, our total target was 43 million, of which we have achieved 95 million. A couple of notes about that. This spells out the specific initiatives that comprise the overall revenue cycle target. And we're doing quite well in overall accounts receivable improvements, the administrative denial reductions, clinical documentation improvement, as well as coverage for the eligible uninsured. I would say the rest are relatively small initiatives. We're continuing to track Medicaid fee-for-service high-cost outliers. I will say our feeling is we've achieved that and we have some good work going on there, but we continue to track it just because it's a body of work that takes quite a bit of time. Our medical necessity denial improvements, there are actually two components to this. One is working with a vendor to overturn denials, and the other is to successfully reduce actual medical necessity denials. And I'm happy to report that we're doing well on both of those categories. Going back up, the administrative denials are really comprised of several subcategories of denials that we receive, and we've made significant progress in reducing our denials for timely filing as well as for provider enrollment. Two very vexing, annoying, and totally avoidable categories of denials. We've been applying a real process improvement framework to each of the denial categories. We have cross-facility work groups with the patient accounting departments, managed care, revenue cycle services, really digging in and working through the root causes, testing different solutions, working with the payers, and really trying to minimize these denials. So I wanted to highlight one area. It is on the prior page. We called it coverage for the eligible uninsured. Here I call it financial assistance. And I really wanted to do a little bit of a deep dive here to show everybody the great work that's happening in this area. The top chart shows that we're exceeding target for outpatient, inpatient, and the ED. So I've demonstrated here what our screening rate target is for each of those areas. We're hoping to achieve 75% for outpatient, a 95% screening rate for inpatient, and 85% for the emergency department. We are actually exceeding each of those targets with a phenomenal 91% for outpatient. That we felt like 75% was a little bit of a stretch, and the facilities have really stepped up for that 91%. Our 97% on the inpatient is pretty consistent with what we've done in the past, and 87% on the ED as well is consistent with last year, but a huge jump from fiscal year 20. So we're not just exceeding all of our goals, but improved over last year as well. In the middle section, we're focused on outcomes. So for those patients who are financially counseled, what happens? Overall, in fiscal year 21, we financially counseled 81% of our self-pay patients. In fiscal 22, through the first quarter, that's 92%. Of those, the percent of patients that were either enrolled in health insurance or financial assistance was 80% last year and 85% so far this year. So we're happy to report that improvement, and this is a number that we continue to track as to what are the actual outcomes of the financial assistance screening. Then lastly, this is a very new metric for us, but we're looking at the timing of that financial counseling. I've said it before in this forum, but our target is for outpatients to provide the financial counseling prior to their engagement with the system. So really, at the point that a patient schedules an appointment with the system, we have a mechanism set up to transfer when a patient is identified as self-pay, to transfer them over to a financial counselor at that point and do the work of identifying insurance, enrolling in insurance, or enrolling in financial assistance prior to the point of service. At this point, we're screening 66% of our patients prior to or on the date of service. We don't exactly know how that compares to history. We're starting to track that now, but our sense is we were a little bit surprised at the number. We were pleasantly surprised. For ED patients, we're screening them. 84% of patients that arrive in the ED identified as self-pay, we're screening 84% of them within either at the point of service or within 72 hours of discharge. So again, good results. Both have room for improvement, which is great, and that's where we're continuing to focus our efforts.
Okay, moving on to test and trace. We started with a slide from the last deck back in December. You can see here that our FY21 expenses came in at a total of $1.44 billion. In quarter one of FY22, we committed about $330 million towards what at the time we were projecting FY22 expenses at $1.48 billion. We'll go through some of the added Omicron expenses in the next slide, but just caveating that this slide is pre-Omicron, so $1.48 billion at that point. OMB has continued to provide us sufficient revenue through the T2 MOU, and that is still true as we have entered phase 4 of COVID response. So if you'll take us to the next slide, we can go through some of the just incredible programmatic changes that have been happening over the last few weeks. It's been a quick and a quick ramp up with cases. So going into this, I've provided an expense estimate by pillar. This is all preliminary dollars, so subject to change. And I'll go through some changes that have even happened since I wrote this slide. But so reiterating that OMB has committed to funding us as we respond to this. But starting with testing, testing has responded to Omicron in, I would say, two buckets. One is increasing access to the public for testing. So that has been through a number of means, increased staffing and expanded hours at our existing sites. The use of additional vendor mobile units and vendor-run pop-up sites. We've also purchased a number of rapid test kits that are being distributed to the public through our testing sites and CBOs. The second bucket under testing is, our school program. So T2 runs the school surveillance testing program. Prior to Omicron, we were testing 10% of unvaccinated students weekly. Now that number is 20%. We've also been a part of, purchasing rapid test kits for the test to return program that's been implemented this month. For tracing, we have hired several hundred staff to respond to the increased workload. There's also been automation of the work and streamlining of the work to manage that massive workload that they've seen over the last few weeks. For Take Care, this is our isolation pillar. We've added a third and fourth hotel as of last week for people to isolate at the hotels. We've seen a rapid increase in demand for that program. And we expect to open a 5th hotel this week. So that is one of the changes that has happened in the last few days. And then for our vaccine pillar, we have increased staffing at our 3 T2 sites to respond to increased demand for pediatric and booster shots.
Yep. I think that's what we have, Frida. There's a couple of slides in the back. I don't know if we necessarily have to go through those. Obviously, we certainly can, but we just put a couple of other things in the back there.
Okay, well, thank you very much for a great update, as always. I'm gonna go through and see if people have questions or comments. I'll start with Jose.
I have no questions. Thank you.
Great, thank you. Dr. Katz,
No questions, thank you.
thank you. Sally,
I have a couple of questions. First, I guess a comment. Whenever I look at the strategic initiatives slide, it's always so overwhelming because each one of those initiatives is a tremendous undertaking, and the success that we've been, is so impressive. Similarly, with respect to the financial assistance screening rates, just tremendous improvement. I do have one question which has been in my mind. We have this New York Cares money, and it's been allocated over time. And we take in patients and we insure them. And then as we continue to get funding, we'll be paying for the costs of new patients as well as patients who continue to come to the system. And so on a worst case basis, if we assume the program doesn't get funded, there's going to be some core amount of subsidy that's going to be required on an ongoing basis for the New York Care patients that are enrolled. One, how much money do we have left now? And then two, do we have a sense of what that core subsidy is that we would need on an ongoing basis to be made whole?
I'm gonna let John do the finance, but I want to do the top points. Remember, Sally, that when we introduced this program, one of the premises of it was that these are our patients to take care of.
Anyway,
This is the reason that health and hospitals exist,
yes.
is to take care of the uninsured who can't access care, especially outpatient care, because while anybody can go under EMTALA to any hospital and get care, there's no outpatient care, and it's the outpatient care that prevents the complications of hypertension and the complications of diabetes. So the money that we got was never meant to cover the cost of the care. It was meant to cover the cost of the add-ons. So, for example, having a 24-hour phone line dedicated to customer service for patients, being able to advertise the existence and an increase in the number of primary care doctors who could handle, because part of the promise was that we would provide a primary care appointment within 2 weeks. So if, that sort of core funding, which supports the add-ons, and additional pharmaceutical hours, that was another one, that the money enabled us to expand the number of pharmacy hours. I think that if the program itself, if the central funding stopped, we would come back to the board and look at how this fits in with what we do anyway. And we would, we might have to let go of some of the advertising aspects of it. But again, these are always our patients to take care of. And so I can't imagine it would ever be anything about not caring for them. But we'd have to sort of retool, how we're doing it. Of course, the money that Matt and John and his team have brought in that so stabilized the rest of Health and Hospitals gives us the money for the mission of taking care of these people, which we didn't really have when the program was first initiated. We were in a much more precarious financial position, right? We didn't have that nice curve that John showed of the patient revenue going up. Part of, to me, one of the big breakthroughs that we had 4 years ago was that the mission of Health and Hospitals requires aggressively billing insurance for insured patients so that we can take care of everybody else. And that's been the work in progress, and year to year, they keep delivering. And so I feel better and better about our ability to care for the uninsured, regardless of what happens with this particular named program. John, can you provide Sally a more quantitative answer?
Sure. Yeah, no, well, first I just say I completely agree. I think it's something very powerful about, having a card, right? Because we issue a card to an individual, and then they have a doctor or a clinic really that they call their own. So it's not necessarily insurance, right? But it helps us, with, making sure that they have the access to care that they need. If we go back in time, the funding, I think, started off at 25 million, then went to 50, 75, and now we're at $100 million. And we're in the process of evaluating how much of that 100 have we actually spent. Our preliminary estimates are that we spend it all. We're taking a couple of different, cuts at how to do the analysis because we have better information now. But it is helping 80 to 100,000, people, which is really quite remarkable. It's proven to be very valuable, I think. And it will certainly be, this re-estimate will be part of our, January budget for next year. Anything else, James? Okay.
Okay, thank you very much.
Great.
Hello, it's Barbara.
Go ahead, Barbara. Sally, are you finished? Sorry.
Yes, I'm done. Thank you.
Okay. Yeah, Barbara, go ahead.
Yeah, I love all the wonderful work the dream team, if you don't mind me calling everyone, have accomplished. I keep thinking about the children, and now we see with Omicron that the kids are affected greatly. And I know that we have school-based or school-oriented activities going on. I just think that perhaps we may think of some more that we can do to close the gap and the risk that children are experiencing right now. Any ideas or any plans for doing more with the school-based work we have already, and also maybe some new initiatives?
That's great, Barbara. Let me talk some more to the programmatic team. I mean, we are doing a lot. We ensured, and I know this is close to your heart, that it's only because of Health and Hospitals that there's a nurse in every single school for the first time ever.
Yes.
We're doing a lot of testing. We have Jen Haven's team doing mental health support for young people and mental health assessments, because we think that's a huge area of need, that kids who have been sort of harmed by the pandemic have a lot of mental health needs, as you say, Barbara. We're doing a lot of testing, but and our hospitals, of course, are seeing kids, although predominantly the unvaccinated kids, the 5 and under. We're not seeing very many, vaccinated kids. They're doing fine, so we have to keep moving on the vaccination levels for the above 5, and hope that science soon provides a safe vaccine for the younger ones. But we'll keep working on it, Barbara. And if you or any other board members have ideas, we are always open.
Thank you.
Great. Thank you. Fenioski?
Thank you, Frida. I just have a question again about the great news, following up on the issue of the NYC Care. Can we go back to the slide if it is possible? I think we're showing 91% of the people.
The financial assistance slide, right?
Yes,
Yeah.
yes. That, in the one before, yeah.
This,
Yes, that one.
sorry.
Thank you. So I think first of all, great work. And can you elaborate a little bit more when you say currently 85% of patients screened are enrolled in health insurance or NYC care? What other health insurance are we talking about? Is that Medicaid or are there any private? I just want to understand the components or the moving pieces of this part.
So primarily the patients are enrolled in Medicaid, and a lot of the 85% is emergency Medicaid. So it's Medicaid that only activates under an emergent situation. In those cases where patients are enrolled in emergency Medicaid, they're generally also enrolled in NYC care for their regular medical needs. In addition to emergency Medicaid, there's traditional fee-for-service Medicaid, Metro Plus, Health First, as well as some other plans.
Do we have a
And-
breakdown? Oh, sorry, go ahead.
No, go ahead. Go, please.
No, what I'm trying to understand, I think this is wonderful what you just said in the case that we take care of the emergency and providing emergency Medicaid, but at the same time connect them with NYC care so that they can continue to have the care after the emergency. I think that's good. But I don't know if there is at one point, and I will leave it to Frida, that we can maybe break down how what insurance we are able to place our or help our patients to enroll, because you mentioned several right now, and it would be good to know like the percentage of where do they normally go, and how does that differentiate between emergency and the regular care that they may want to or they should receive.
Absolutely. We do have that breakdown and track it regularly. I don't have the numbers off the top of my head or with me.
Okay.
Yeah,
I can have it later. Yeah.
Yeah, this is again, along with denials and some, this is like one of the primary focuses that we have within RevCycle. It's so important, right, that we connect, with our uninsured patients, right, and put them on a route of either getting insurance, which would be great, right? That's the ultimate goal. And if they're not eligible for insurance, enroll them in NYC cares, because the alternative, what happens is that they receive care and then we have to send them a bill, in some cases a very large bill, and we don't need to do that, right? Because we can discount that bill significantly if they're not eligible for insurance and enroll them in NYC care and have a clinic and a doctor that's their own. And the other thing is, it could be a deterrent of care. If you have a big bill, right? Nobody wants to get a big bill that they can't pay for, right? It's just, and it's not who we are. So we, even while these are great numbers, I think Margie and team, we all recognize, if we come back a year from now, our hope is that we show even further improvement for all these important reasons.
On that point, John, so I was going to ask a question, and Fenny, I'm sorry to
No, go ahead.
But the 85% of patients screened are enrolled. Could we get to 100%? And what are some of the reasons, where the 15% are missing?
So the 15% that are missing are either patients who don't complete the requirements. So if we need certain documentation to complete the screening process, so that's part of that. Part of it is they're not eligible for any of the programs. So we want to screen everybody, even people who say, no, I'm not going to be eligible, because it's part of the screening process for uninsured patients who don't fall within the income parameters. We do have a greater, a top tier, if you will, where we do provide a self-pay discount so that we don't charge charges to patients. So that would also be part of that 15%.
Okay, so there is going to always be some proportion that we can't get enrolled, right? And that's realistically, right?
Yeah.
Margie, isn't there also a small group of people who are outside of New York City that under the FQHC mandate, we also have to serve?
Hmm.
Well, yeah, and that's a very good point. Thank you, Dr. Katz. There are patients, both, I think H&H options is a little bit broader. If you live in one of the surrounding counties, you're eligible for H&H options, but not NYC care. And then patients that come visit New York City and end up in one of our hospitals for one reason or another may not be eligible.
Right. Well, I think that tracking all of this data is first of all amazing because that helps us identify, where the pockets are and how to improve on that. So I assume a lot of this in terms of Epic and in my chart and everything helps on all of these initiatives.
Yes, absolutely.
It was probably 20% 4 years ago, Frida, if that.
Right.
Wow.
Again, it was one of the crucial insights about how to get health and hospitals back on track.
Yep.
Was that there was a misconception that since we take care of everybody regardless of insurance status, there's no reason to screen anybody for insurance status.
Right.
And obviously, that's a mistake. And when Margie screens people, she helps them enormously by enabling them to then get benefits often beyond NYC care that will take care of them no matter where they are. So we're really making people's lives better by doing this, but it's an area where the system has improved tremendously.
Yeah. And same with the revenue cycle, that same narrative there. Sorry, Fenioski, I didn't mean to interrupt you. Do you have more questions?
I just have a question, and I don't think there will be an answer right now. I would try to make it short. You mentioned the self-paying, for whatever reason, they cannot be that 50% that cannot be. When you send the bill and you set a discount, is that discount equivalent to the discount that we more or less give to the insurance company, or is totally separate? Because what I find, and again, maybe I'm being naive here, is that if we already negotiated with insurance company, what is the price that we are willing to accept, or the amount of money that we're willing to accept for a procedure, and somebody is paying for whatever reason, will it be okay to give them the same cost instead of having the inflated cost that we never get paid for? So getting the discounted insurance cost instead of the inflated one, and a minimal 10% discount. Do you understand my question? Or?
I do.
Yes. Go ahead, Margie.
So when a patient has completed screening and may not be eligible for financial assistance, we bill them, we give them what we call a self-pay discount. And we set our self-pay discounted rates in alignment with what Medicare reimburses us.
Oh.
Which is more than Medicaid. Right.
It's in most instances, not 100% of the time. In most instances, it is more than Medicaid, and it's set at that Medicare rate.
Okay,
Patients
that's very
always,
helpful.
and patients always have the opportunity to reach back out to us if that's still too much, because the Medicare rate, it could, for somebody without insurance, that can be quite a lot, and we have a fee settlement board that will review any special request.
And I'll also add, there's a lot of discussion and actually a requirement around price transparency. And Margie and her team have done some analysis to see, how do our prices compare, right? Because we now have the data to other hospital systems in the city. And our preliminary analysis indicated that, we do, quite well. again, we did a service by service, right? Those services that we thought were important, and we did our best at an apples to apples comparison, and we thought we did pretty well with that.
And I
And you
think
actually
that
can-
was included in the materials last finance committee meeting.
That's right.
Yeah.
Yeah.
That's right. And you can actually go onto our websites, each of our facilities, and find out what the self-pay rate would be for any number of procedures.
Interesting.
Yeah.
Thank you. Thank you.
Great. So I think I have just a couple quick questions, and one is just on the FEMA dollars. I wanted to understand I've seen reports of $1 billion and change that we're going to get. That's including the 650 million we've already received, correct? It's not an
Yeah.
incremental.
That's
amount.
right.
Okay, so we'll still be a little bit short of our 3 billion of expenses we had prior to the Omicron wave. Is that
Right, so we still have subsequent requests to FEMA that will go in for approvals in addition to that $1 billion that was recently approved.
okay? And then in terms of the fourth wave, the Omicron wave, are there opportunities still for that, Linda, FEMA or more PRF funds or?
We anticipate submitting those costs to FEMA as well. We are not sure that there will be additional PRF funds. We do have, as I said, the small amount, the 15 million that we just received, that can be used for this period, but we're expecting predominantly for that to be funded through FEMA.
Okay. And in terms of, this really just two quick questions. In terms of the temporary staffing and the needs there, are we, Micheline, I know you spoke of the plans and all the preparation and avenues. Are we able to get the staffing, and, you know, are the costs dramatically higher, or could you give a little bit of context on how we're doing there?
Yeah, so it's a mix, right? So we're basically getting in as many as we can on the nursing side for sure. And we activated already 2 other vendors to speed up getting bodies and seats, so to speak, quickly. So we ordered even more actually than the 800 so that when we can hopefully get them in faster. So we have right sourcing and 2 other vendors, and they support each other to get those in. In terms of the rates, we've been using the rates within the same ballpark or range that we have used in previous surges. So they are higher than our normal bill rates by those vendors, but they're within the range for surge planning.
And I'll just add, what we've tried to do in this wave in particular is also enhance the amount we pay for overtime for our own nurses and for our own doctors and providers, right? We would prefer to pay our own staff more money, but they're tired and they're also getting sick. So we had to find this right balance. And I think we're there. You know, they flew in. Some of them flew in on Friday, are being trained as we speak, and they'll be on the floor if they're not already expanding some capacity at certain hospitals. So everything's on the table where we deploy everything. We move all the levers, as Dave Silvestri says.
Coney Island opened up their new ward this morning.
Wow.
It was a good decision. I mean, we went back and forth about it because the rates are high.
Right.
And we didn't want to pay them if we could get by with only the regular registry, but it turned out we could not, and that was clear last week. So we made it through last week, but it wasn't easy. And now with the new wards opening, we're doing much better.
Good. Right. It sounds like you guys made the right decision and have been planning well. This is just a question that on the, the trends in patient care seem to all be good, visits, discharges. And CMI, I think you mentioned, Micheline, is up relative to this time last year. So that would be relative to a COVID period, right? We're comparing.
Right.
Do you have a sense for what that's attributed to? Or it's not a huge amount, I don't think, but.
I would have to look into that exactly, but it's generally basically the patients that we are seeing, but also combined with our revenue cycle efforts can have an impact on the CMI because we do focus on our high acuity and high need patients. Right, Margie, would you say that also has
I
some
think
other-
also it's that, and I can speak to this personally, we've had an Epic for a while, but doctors and other providers get better at it.
Right.
As you use Epic, I mean, for good and for bad, Epic is a product that was built for billing, right? Every time I have to do a click, it's to create a bill. And as we get better and better at it, we add more diagnosis, and it is getting closer to truth. I mean, it isn't fake, right? It's just that you learn how to document more of the diagnoses so that maybe once because it was faster, you put in one diagnosis, diabetes. But now you've learned that with a few keystrokes, you can put in diabetes, hypertension, and elevated lipids. And it pushes up the CMMI, and it's all honest. It's not, nobody's padding anything.
Yeah.
But in the old days, it would have been too difficult, or even if you had Epic, you didn't realize exactly how to do it.
Yeah. Yeah, that is actually kind of what I was wondering, because I know, we were seeing pre-COVID early on the increases, and that I felt it was a lot due to just better, diagnoses codes and right. And so now I'm wondering if that's still continuing, and it sounds like, Mitch, you're saying that it is, and so some of that is.
Again, it is because as you chart a patient over time, you place correctly the diagnoses.
Right.
And then when you start ordering tests, the diagnoses automatically repopulate for you to say whether or not the tests are due to this particular diagnosis. And so you don't have to go find the diagnosis anymore because you've already put it in under the problem list. So all of these things make it easier and easier to more correctly document the illnesses people have, and that's what pushes up the CMMI.
Right.
And I would just add to that, there's one additional factor. Everything that's been said so far is true. And starting last spring, we started bringing in a secondary level review process. So the coders, the clinical documentation specialists work real time with the providers on the floors to make sure that the acuity of the patients is documented well. And then it goes through a secondary review process with fresh eyes looking at those cases. Historically, we used a vendor for that. And starting last spring, we started bringing it in-house with our own staff, that secondary review process. And that's proven quite successful.
That's great.
So that's also helped stabilize the CMI.
That's terrific. And one last question, and this is on, and by the way, bringing it in-house, I think, is terrific that we're able to do that. Is on T2, and Sarah, I think you, amazingly, the work that's been done with the Omicron, and you gave us a good sense of that, and all the activities and changes that are happening. I just wondered if those incremental costs that you referenced in your slide are those, because we approved a bunch of contracts last meeting, that some of that was to address some of the changes that were occurring, but I didn't know if these were incremental costs above and beyond that, or sort of inclusive of that, or.
Yeah, this would be incremental above and beyond what we talked about in early December, because I think at that point we were, it was pre-Omicron, and we've had to ramp up work, so we would expect to eat into the NTE and those contracts a little faster with this. So we'll have to do some, looking back at that and figuring it out. Yeah.
Okay, so that's an evolving situation. Obviously, we may have to revisit those again at some point. Okay. So that was it. I want to thank everyone for.
Oh, I have a quick question,
Go
Frida.
ahead, Sally. Sure.
Actually, I think Mitch told us in a very informative way about how differently Omicron patients are presenting.
Mm.
That about half of them being patients that have different diagnosis but are COVID positive, and then half of them being folks who are COVID positive, but the average length of stay being very short, like 4 days. So it's really, I think of it as a turn. It's a lot more coming in and a lot more going out, in addition to patients who aren't primarily there for COVID. But it was a very interesting to understand the differences between the way COVID manifested earlier.
Interesting.
That's clear.
Well done, Sally.
Yeah,
All right,
excellent.
thanks. Liz. I'm
Explain.
not sure I said it clearly, but it was very
The
helpful.
clearest one sentence is that we have all these COVID admissions, but our overall census is flat.
Interesting.
But I think our challenge is we have more of our own staff out sick, right? So it's always throwing
Correct.
another curveball at us, right?
Correct. The challenge of this round isn't the census. The challenge of this round is a quarter of our staff are sick,
Right.
not available to take care of another interesting metric is last week we were getting 120 nurses through our first nurse registry, and we only got 93 because the rest tested positive for Omicron.
Oh, wow.
Wow.
So, right. So, of course, when you start thinking about it, that makes total sense, right? With all this community transmission, just because you get registry nurses doesn't mean they're also not going to get sick.
Right.
Right. So we're all struggling, but this week is better than last week. And the projections are that new cases are plateauing. So even if hospitalizations and deaths increase, because usually they lag. So if the cases peak this week, there'll be a couple of weeks before hospitalization and deaths peak. But we'll be in a better position because if cases peak, we won't lose so many people
Yeah.
out. More people will start coming back than are going out. And at least if Omicron is like other waves, people will not get Omicron again. Right. Whether
Right.
they'll get something else again, we don't know. But they
Yeah.
won't get Omicron
Mitch,
again.
are we using the 5-day isolation period or 10 days? What are we doing?
We are, but remember that that's only true if you're asymptomatic at 5 days.
Right.
So,
Right.
I wasn't asymptomatic at 5 days. I could work from home, but I couldn't have gone into the hospital. Right.
I see.
So, we're very good. We don't pressure anybody. We don't,
Right.
people get 10 days of sick leave, not accruing against their regular sick leave.
Okay.
So the people who come back at 5 days are many of the people who were never sick.
Mm-hmm.
They had an exposure, they went and got a test, and the
Right.
test was positive. And so, they're just sitting at home isolated, and in 5 days, they're happy to come back. But the people who get symptoms are usually not well enough by day 5 to come back. And most people are not coming back at day 5. Most people are coming back at day 10.
Right. Okay.
Okay. Well, I'm glad that this week is better than last. That's the right direction anyway. Thank you, Mitch.
Thank you.
So if there's any old business, new business, there being no further discussion, the meeting is adjourned. Thank you, everyone.
Thank
Thank
you.
you.
Thank you.
Bye-bye,
Thank you.
everyone. Bye.
Thank you.
Bye-bye.
Thank you.
Thank you.